In this case of a typical African nose, we did have the same issue with the width of the nasal bones, despite the fact that we did not have any height in the nasal bone. We did have a short stump of the nasal bone from the length and the height aspect. We had to manipulate the nasal bones here. The issue is that it is susceptible to collapse if it is touched, but using the piezotomy, keeping the dorsum intact and not touching the continuity of the dorsum, we just made 2 lines of medial oblique osteotomy toward the medial canthus, and we continued the lateral osteotomy also at the level of the junction between the cheeks and the nasal bones to make it as thin as possible. Because of the large inferior turbinates inside, we had to keep the lowermost part of the nasal bone intact, where it is called the Webster triangle, in order to keep the large inferior turbinates lateralized. Then we use the rib cartilage to augment the dorsum with just diced cartilage and fascia, and the very thick skin envelope of the nasal tip was reshaped by using a strong septal extension graft from the rib cartilage, and also reposition of the cartilages which are located and oriented toward the medial canthus to a new axis toward the lateral canthus in order to decrease the bulbosity and the convexity of the lateral crus on both sides, and also to augment the dorsal profile as much as possible, as much as the skin lets, due to the wide dissection that we have in all cases in order to reach the level of the attachment of the nasal bone and cheekbone. We do have the ability to borrow some skin from the cheek, also decreasing the width and the total width of the nasal bone, and the bony pyramid lets the skin to be a bit looser and come up a bit to recreate a more aesthetically pleasant curve on the nasal dorsum. The nasal tip was planned to be a bit more projected, so the depth of the curve on the radix area became much more in the operation, so we needed a considerable height of the diced cartilage and fascia graft and a considerable amount of cartilage for augmentation of this dorsum. But if we would not touch the nasal bone, despite bringing the bridge upper and make it thinner, the effect was less than now that we have osteotomized the lateral parts of the nasal bone attachment to the cheekbone. Also, the retracted columella, which causes an acute columella-labial angle, was corrected by extending the septal extension graft of the rib into the angle, and the total width of the nasal tip was decreased by reshaping and also increasing the projection of the round part of the nasal tip. At the end of the operation, the level of the nasal bones have become much closer to each other to close the gap and the width that we had, the attachment of the nasal bones and cheekbone, and also we have a very gentle curve here. The curve is decreased considerably with augmentation of the dorsum, but we still have a little curve here, not that much. Also, the nasal tip is more defined by the means of using a column, a strong column of cartilage, used the sixth rib, and also the diced cartilage and fascia has made a stable long-term dorsal profile, which still has a curve, but the curve is more natural in comparison with what the patient had. Also, the width of the nasal tip is decreased. As is evident from all views. We do have a symmetrical pyramid of the nasal tip. It is a bit longer, so it is pyramidal. It has become more pyramidal. The dome shape appearance of the nasal base and the wide and transverse axis of the nostrils is totally changed to a more pyramidal and stable appearance with thinner and sharper and more defined nasal tip. The profile and the thick skin envelope here is reshaped in a new position.